Hi everyone, welcome back. This is part of the video series on anemia, and in this one I'm going to do a deep dive on iron deficiency anemia. This is very high yield both clinically and for board exams, so if you're ready, let's get started. So iron deficiency anemia is primarily considered a type of microcytic anemia. Microcytic means cells are small or micro. So this is defined as anemia where the MCV, which is the average size of the person's red blood cells, is less than 80 femtoliters. The normal range of the MCV is 80 to 100 femtoliters. So it is microcytic because the cells are smaller than normal. There are 5 main causes of microcytic anemia, which you can remember by the mnemonic TAILS. Stands for thalassemia, anemia of chronic disease, iron deficiency anemia, lead toxicity, and sideroblastic anemia. And of these, anemia of chronic disease and iron deficiency anemia are the 2 most common causes. And one caveat is that both anemia of chronic disease and iron deficiency anemia can not only cause microcytic anemia, as we're learning here, but they can also cause normocytic anemia, where the MCV is going to be normal and between 80 to 100 femtoliters. What's very important to know is that the underlying mechanism for microcytic anemia is always going to be decreased hemoglobin synthesis. So regardless of whichever one of these conditions is causing microcytic anemia, the reason for the anemia is going to be decreased synthesis of hemoglobin. So now let's talk about the hemoglobin. It's the main thing inside of mature red blood cells, and that's because it is what actually binds the oxygen and helps carry it and deliver it to tissues. As you can tell from the name, it's made up of 2 parts, heme and globin. Globin is a protein. It has 4 subunits or chains, 2 alpha and 2 beta. And at the center, we have the heme, which is made up of protoporphyrin and iron. And iron is a very important part of hemoglobin because it's actually where the oxygen binds, and it's an essential part of it. So you can't make hemoglobin without iron. Therefore, if our red blood cells have less iron, that means they will have decreased hemoglobin synthesis, which is why it causes microcytic anemia. Okay, so now that we learned all about iron, let's learn about iron deficiency anemia, which is the I in our TAILS mnemonic. Iron deficiency anemia, or IDA, is the #1 cause of anemia in the US and the world. The problem is that there's a low amount of total iron in the body, which means that the red blood cells have less iron, which means they can't make heme, which means they can't make hemoglobin, and by now you know that that means microcytic anemia. Okay, so then what are the causes for the body to be low in iron? You can think of it in terms of either decreased intake or absorption, or increased demand or loss. So let's start with decreased intake from the diet. This is due to malnutrition or vegetarian diets, or in infants that are exclusively breastfed without any iron supplementation. Decreased absorption is when you have a problem with the GI tract, so you're eating enough iron but you just can't absorb it into the body, and common causes can be celiac or other intestinal diseases, surgeries such as gastrectomy, and then also, since vitamin C is important for absorption of certain types of iron, vitamin C deficiency can also lead to iron deficiency due to problems with its absorption. Increased demand usually occurs in childhood due to growth. Also in pregnancy, this is a very important and common cause of iron deficiency anemia. And then finally, patients who have chronic hemolytic diseases are going to have an increased demand for iron because they're constantly breaking down and hemolyzing red blood cells, so they need more iron to be able to replace those red blood cells, and so they can actually get a secondary iron deficiency anemia from their hemolytic disease. And then finally, increased loss occurs in the setting of chronic blood loss. This is the only way that we lose iron from our body. And the most common thing that we see clinically is due to heavy menses, but you should also keep in mind that you can have a slow occult bleeding in the GI tract, for example, in the setting of colon cancer. So this is a can't miss diagnosis that you have to consider. Now let's talk about the symptoms of iron deficiency anemia. So all anemias are going to have symptoms of tissue hypoxia, which is shortness of breath or fatigue, but there's a couple of symptoms that are more unique to iron deficiency anemia that you don't get to see in other anemias, so it's helpful to know them. One of them is koilonychia, which is spoon-shaped nails, and the other one is pica, which is the craving of substances that are not nutritive or food. The most common case here in iron deficiency anemia is craving ice. Okay, so now let's say you have a patient that you're suspecting iron deficiency anemia. How are you going to make the diagnosis? The most important test is going to be the iron studies. This is the one that's going to give you definitive diagnosis. What it's going to show you is, since your total body iron is low, the serum iron and the ferritin are both going to be low. And since the ferritin is low, the TIBC is going to be high because they always go opposite. And since the serum iron is low and the TIBC is high, then the percent SAT is going to be low. And if you watch my video on iron studies, then you already knew this. If you haven't had a chance yet, I'll link it at the end of this video so you can check it out. I think it'll help you a lot. Now, besides iron studies, there's a couple of other findings. On the peripheral blood smear, you're going to see hypochromia, Hypo means less, chromio means color. So this literally means that these red blood cells are going to be pale with an increased zone of pallor. And you can see that when you compare the red blood cells on this hypochromia smear with this one with a normal red blood cell smear. And the reason for this is because of less hemoglobin inside those red blood cells. So all microcytic anemias, not just iron deficiency, but all of them are going to have hyperchromia because they all have less hemoglobin. But on test questions, it's usually used in the setting of IDA. So just keep that in mind. The other important clues are in the labs. So you can get an increased RDW. RDW stands for the red cell distribution width, and this is basically just a range of the red blood cell sizes in a person's blood. And since in iron deficiency anemia, the red blood cells usually start off as normocytic and get smaller as the disease progresses, this is going to create a wider range, and that's why it's going to have a high RDW. The other test that's going to be helpful as a clue is going to be a high protoporphyrin level inside of the red blood cells. Normally, protoporphyrin binds iron to form heme, but there's no iron around to bind, so protoporphyrin is just going to hang out unbound, so the free levels are going to be elevated. And now finally, let's talk about the treatment. So once we've made a diagnosis, how are we going to treat iron deficiency anemia? And there's basically just 3 things to consider. Number 1, of course, is going to be to have the patient take iron. Most commonly, they can take it orally, but in more severe cases, we can also give iron infusion IV. If the anemia is really severe, then we can actually transfuse them with red blood cells to fix the anemia right away. And then finally, this is the most important one that I want to stress. It's not just enough to treat the iron problem and the anemia, but you have to figure out why is this patient iron deficient, because in many cases, for example, in colon cancer, iron deficiency anemia is literally the first presenting clue that the patient has an occult cancer. So once you recognize iron deficiency anemia, you can't just stop there. You have to go and work up the patient to figure out the cause of the iron deficiency and rule out serious causes. Okay, one point that's important to emphasize again about iron deficiency anemia is that it can cause both micro and normocytic anemia. So let me explain why. So let's say that we have someone who's going to develop iron deficiency anemia due to chronic blood loss over time. They're going to start off first looking like this with normal sized red blood cells and normal hemoglobin content in the very beginning. But then as they begin to lose red blood cells and therefore iron, they're going to decrease synthesis of hemoglobin. And so what's going to happen is that the concentration of hemoglobin inside the red blood cell decreases, but the cell size remains the same. So in early iron deficiency anemia, the hemoglobin is down, but the red blood cell size initially remains in that normal 80 to 100 range. So early iron deficiency anemia is normocytic. Now, as this person loses more hemoglobin, then the red blood cells now have to get smaller because each red blood cell has to meet a minimum hemoglobin concentration inside of it in order to be released from the bone marrow and enter the circulation. So when the hemoglobin concentration has decreased a lot, as happens in this advanced or later stages of iron deficiency anemia, then the red blood cell has to adjust its size to become smaller so that it can meet that hemoglobin concentration requirement to be released from the bone marrow and enter the circulation. And that's why their size now is less than 80 femtoliters. You can see that it's smaller, and so it is microcytic. So this is why early iron deficiency anemia is normocytic and later iron deficiency anemia is microcytic. And this is also why there's generally an increase in the RDW, which is the range of the MCV size, because there's a gradual decrease of RBC size as the disease progresses. All right, and let's finish with one final thing about iron deficiency anemia. This one is a very rare condition clinically, but it does show up on board exam questions. It's called Plummer-Vinson syndrome. It's a classic triad of iron deficiency anemia, esophageal webs, which are thin membranes in the esophagus that can cause obstruction, and dysphagia, which is difficulty swallowing, which is caused by those esophageal webs. Now, the exact linkage of the iron deficiency anemia isn't clear here, but it's thought that the anemia is more likely the cause of these esophageal problems, not the consequence. So in other words, someone has long-standing and severe iron deficiency anemia, and this severe lack of iron in the tissues of the esophagus causes there to be thinning membranes and weakened esophageal muscles, which is then going to lead to the formation of the webs and the difficulty swallowing. Lack of iron can also damage the cells of the mucosa of the mouth, so it can cause atrophic glossitis, which is inflammation of the tongue, or angular cheilitis, which is inflammation of the angles or corners of the mouth. And then finally, it's important to recognize that Plummer-Vinson syndrome is associated with an increased risk of squamous cell carcinoma of the esophagus. Okay, that's it and that's all. If you want to learn more about this topic, you can check out some of the other videos that I've linked here. And if you guys enjoyed this video, don't forget to like or drop a comment and let me know. Also, don't forget to share this with others and subscribe to the channel so that you don't miss out on upcoming content. But for now, thanks for watching and I'll see you next time.